All right, welcome everybody. Thanks for joining us for another episode of the group chat. Just some housekeeping items before we start. There will be a Q&A at the end of the presentation, so you should see a little Q&A box on your screen. Feel free to submit questions throughout the presentation. I'll compile them at the end and go through them with our speaker. This presentation is being recorded, however, no attendees will be identified. All images used in this presentation are the property of their respective owners. And as a reminder, the information shared during this presentation is not medical advice, but we will be providing additional resources at the end of today's talk. And with us today, we have Dr. Lia Miceli. Dr. Miceli is a urogynecologist with AHN Women's Institute, specializing in pelvic organ prolapse repair, urinary and fecal incontinence, and venous procedures. She is with us today to share her expertise on fecal incontinence and the importance of pelvic health. And so with that, I'll hand it off to Dr. Miceli.
Okay, wonderful. Thank you so much, Bree. Lia Miceli, great to be here today. I'm one of the urogynecologists with the network. And I'm here today to talk about something that bothers a lot of women, and that is fecal incontinence, which I know can often be challenging to talk about. And so happy to use this platform to give a little more information and hopefully answer some questions. So we'll talk today about definitions for leakage of stool, risk factors, how we evaluate this problem, treatment ranging from conservative all the way through surgical treatments, and then who you can reach out to if you're looking for help for this. So what is fecal incontinence? And so really it's a loss of stool that's involuntary. But the question is what do we call it? How do we talk about it? And so just to start off with, we did ask women how they prefer to talk about this troubling issue. And they found that patients really often prefer to call it accidental bowel leakage rather than fecal incontinence. It's a little more palatable, I guess, to get around and to discuss. So if you see that phraseology going forward, it's two in the same. We're just moving towards different terminology. So really what this is, as I mentioned, it's the recurrent and involuntary loss of solid or liquid stool or mucus from the rectum that is a social or hygienic or problematic issue for patients. Anal incontinence really just it includes all of that, plus the loss of gas with or without stool. So that can also be very bothersome. It's a common problem. There's a large survey of 4,000 women, and it can be up to 8% of people that are experiencing this at any given time. Most commonly, it's related to consistency. Commonly, liquid stool gets leaked the easiest, followed by mucus, and then solid stool. This is a problem that does increase with age, lower in the younger women, but by the time you're 70 years old, it can be up to 15% of the population, and ranging from 40 to 70% of people who are currently residing in nursing homes will be bothered by fecal incontinence. It's a big quality of life problem. And so leading to, and this is all driven by data showing that it can increase rates of depression, these feelings of social isolation and shame, embarrassment. It can really impact sexual function for people. And there is an increased economic burden associated with it, with women, having to buy Depends and pads and seek care. And so pretty heavy impact on quality of life. Luckily, there are people who are here to help patients with this. There's a group of providers that have really rallied around this issue, and we're here to talk about it. We're here to help. So just wanted to talk about some risk factors and why this might happen to people. So very often it's related to a weakness or an injury to the sphincter muscle or to the pelvic floor. And I mean the sphincter muscle on the anal sphincter. Most commonly for women, this can happen in childbirth. And even if it's not a problem earlier in life, later in life, accompanying the changes in menopause, this problem can compound and the weakness can compound over time and show up in the later decades, in the menopausal decades of life. It can often be related to stool consistency. So people who have problems with chronic diarrhea, kind of like the IBS-D portion of the spectrum, or the inflammatory bowel disorders like Crohn's or ulcerative colitis. It can be an issue with stool consistency. And conversely, people with constipation can have a lot of issues with fecal incontinence. And we'll talk a little bit about that going forward. Less commonly, there can be a neurologic injury or a loss of sensation to the rectum or the sphincter itself. There are a lot of medications that can cause fecal incontinence, and we'll go through that. And then, there's the potential that there can be an injury to the bowel or an abnormal communication between either the bowel or the skin and the vagina, or a congenital malformation. And those are definitely more rare, but can happen. And it's something that your provider is going to be looking out for when they talk to you and examine you. So to start kind of with the most common reason, just to describe what the sphincter is it's a network of muscles at the base of the rectum and anus. And really there's an external muscle, and that is voluntary. That's what you can squeeze or release. And then there's an internal muscle, and that's actually involuntary and truthfully leads to the majority of the continence mechanism for keeping in stool. So there's two things that we're considering when we're talking about this muscle complex. There's also an intricate lattice of pelvic floor muscles that your urogynecologist will be evaluating. And you don't have to remember the names of these muscles, but really this is just a diagram to show you that the pelvis is essentially like a bowl. This image here is almost as if we were looking straight down on a person, like from your head. And you can see that this lattice of muscles here, the three of which are highlighted, are called the levator ani muscles. They are responsible for a lot of the continence and tone of the pelvic floor. And if there's dysfunction in them in either direction, too loose or weakness can often cause leakage, and too high tone or tension can cause issues with being able to release your bowels. And so this is a really important factor when we're talking about fecal incontinence, and something that we will be evaluating for sure. There are many medications that can be associated with accidental bowel leakage. And I just want to kind of stop on this slide in case anybody's curious, because many of these are really common. Antibiotics, if you ever have to be on an antibiotic, it really throws off the gut bacteria, and that can lead to changes in stool, changes in sensation, and that can cause leakage. I don't know if you can see my pointer here, but there is a list of antidepressants, and those can also cause incontinence. Those are some of the most common medications to be on, and they impact kind of the nervous structure of the bowel and the consistency of stool. Blood pressure medications like beta blockers or ACE inhibitors can also potentially cause fecal incontinence. And then diabetes medicines, and specifically metformin, that's probably one of the most common ones, and that's usually because it makes stool runnier and can lead to diarrhea. Acid reflux medications are another big one, like the proton pump inhibitors like omeprazole and pantoprazole. And so these are all just things to be thinking about, not necessarily wanting to take you off your blood pressure medicine, but you may be wondering, why suddenly you're experiencing this. And some of the medications that you're taking can really impact the quality of your stool and therefore leakage. There are other risk factors to have leakage of stool. Obstetrical trauma is a big one, like I mentioned already. Chronic constipation or diarrhea. Probably the biggest one is age. It kind of compounds on all of those things. Smoking is a risk factor, as it is with many things. And then obesity is another one it's challenging to talk about in the office, but fecal incontinence will certainly increase in prevalence as we all gain weight. We talked about pelvic floor disorders and dysfunction in the muscles, and then history of radiation and other comorbidities that really can lead to either neurologic dysfunction like diabetes, or changes in stool consistency like the inflammatory bowel disorders like Crohn's or ulcerative colitis. These are all risk to have leakage of stool. So it's important to get evaluated if this is something that's bothering you. And really, as a urogynecologist and a champion for this problem, I firmly believe that we should all be universally screening for this. That being said, office appointments, there's a lot to talk about from everybody's perspective. So please, speak up and mention these things so that we can get you on the right path to getting treatment. Talk to your primary care provider, talk to your gynecologist. They'll be able to get you referred to us or to a colorectal surgeon. But make sure if this is bothering you that you mention it out loud. Mention kind of what type of leakage that you're having, how often it's having, if it's associated with urge, or if it's kind of something that you're not feeling and it's just happening. And then its impact on your quality of life. These are all important things that we'd want to know and for you to think about. Stool consistency is a big thing that we talk about, and I have a funny little picture here, and this is our Bristol stool scale. And so this is actually a validated tool that someone may give you to visually circle what kind of stool that you're having, and just to point out that the type 3 and the type 4 is where we'd all, try to live. where it's the formed stool that is not overly hard or compact, and that this is stool that's full of fiber and normal consistency. If you're in the type 1 range where it's like looking like pebbles, this is showing that you're constipated. And you can be leaking because of constipation, or you can be leaking because of diarrhea if you go down to type 7. So we're all trying to aim towards that type 3, type 4 normal stools, and I will give you some tools for how to achieve that. We would and should do a physical exam as part of this. And that's really basically a vaginal and rectal and a perineal assessment. The perineum is that space in between the vagina and the rectum. And so we want to rule out the really rare things like an abnormal communication between the bowel and the vagina. So rare, but just something to look at. And then also looking to see basically what the quality and the strength of the muscles, both in your pelvic floor and in the sphincter are. We can get a lot of information just from doing a physical exam alone, looking to see if there's history of obstetric injury there. We can tell that just by looking. And so often we don't need to go further than that to treat. But sometimes people may refer for diagnostic testing if the clinical exam is inconclusive, or there are concerning parts of the history of physical exam. But normally we don't need to order any tests before we can get started with treatment. But if tests do need to be ordered, we may think about colonoscopy if we're trying to rule out things like colon cancer. Manometry is a test that both our gastroenterologists and colorectal surgeons do. We don't actually do those in urogyn, but this is basically looking at sphincter function and looking at the capacity of the rectum and how you empty. This gives a little bit more information about the emptying mechanism in general. We can do endoanal ultrasound, really looking at that sphincter muscle, which can be useful if you're considering surgery. But even if we know someone has a history of an anal sphincter tear, we don't necessarily need this to proceed with treatment, but these are all options. MRI defecography is not often necessary. It's uncomfortable. You have to try to release a bolus of contrast in an MRI machine, but it can detect some anatomic problems. Specifically looking at the anal rectal junction, essentially the angle at which the rectum sits at the anus. It can give some information like that, but we don't always need it. So we start conservatively when we're treating this. And so there's actually a lot that can be done without having to do any procedures. And so first and foremost, we want to make sure we talk about dietary management. This is one of the number one reasons to have leakage of stool. And it's basically a response to the things that we eat. In the studies, it shows that the worst trigger and the biggest cause of fecal incontinence are going to be the saturated fats and the fried foods, the stuff that we all love to eat and that tastes so good, especially in the Pittsburgh area. So avoiding these, or at least cutting back on it, can have a pretty big impact. Other things like coffee, alcohol, the caffeinated things, high sugar things, that can also have an impact, but really by the data, saturated fats and fried foods have the highest impact on fecal incontinence. We all want to make sure that we're staying hydrated to avoid constipation. And if you're not sure, keep a food diary. See what you're eating and if it is impacting you, if it's impacting your bowel movements, the consistency of your stools, and then, serially eliminating some of these things that you think might be bothering you can be helpful and important. It doesn't mean that none of us can, we have to never eat pizza again or a hamburger, but may not be something that you'd want to go for if you're out in public and away from a restroom. Bowel habits are also extremely important. Some of this is easier said than done. The regular toileting really insinuates that you kind of have yourself on a regimen. If that's something that you can do, that's not something that all of us can do. But trying to kind of just keep things emptier before leaving your home can be helpful. That seems like a silly thing to say, and it's intuitive, but it's something that we talk about. Tools like a squatty potty can also be really useful. And if you look at that picture on the right is the squatty potty itself. It essentially puts you in a squatting position, which is actually anatomically how we were meant to evacuate our bowels. Because what happens is, like I showed you, that lattice of muscles in the pelvic floor, when you squat down, it actually straightens out the rectum and releases the muscle that acts like a sling and makes it easier to have a bowel movement. So if you are ever feeling constipated, or even if you just want to achieve a more comfortable bowel movement without having to bear down, I do recommend these squatty potties or anything you could use to essentially lift your legs off the ground to get in more of a squatting type position. lower toilets um, can be something that you can install in your home as well, which is tougher as we age and it's harder to kneel, but a consideration for sure. Whether stool is too firm or too loose, fiber is going to be your number one ally in treating fecal incontinence. It's going to be the first thing that all of us talk to you about, in addition to those dietary and lifestyle modifications. So fiber does come from, it comes in many forms. We have dietary fiber, and that's what we think about getting, like the things that we're eating, like, the cereals, the seeds and nuts, certain types of veggies. But beyond, there are some people that can, help their symptoms with dietary fiber. But I do recommend that pretty much everybody gets themselves on a fiber supplement. And the one that I like here is Metamucil or psyllium husk. That's the most bulking and forming and tends to work the best for fecal incontinence specifically. I will go through how to take it here in the next slide. But I just really want to pause on this photo because Metamucil can be your best friend. And so what fiber will do is it both binds and draws water. So if you have a runny stool, it will absorb the water in that stool and make it more formed. If you have really dry stools, it will bring water into those and form it in that way. So it kind of is just like a water absorber binder and works for both runny or loose. I'm repeating myself a lot intentionally. So I'll do it in bold here. What we usually recommend is, because it can be a little bit gas forming when you start taking a fiber supplement, to start with half a serving a day for a couple of weeks and then increase to a full serving. So you're going to have to, everyone kind of individually has to play with the fiber, individually play with their bowel regimen. There's not a one size fits all. So we usually say kind of start at a half and increase it. We want you to drink 8 ounces of water with each supplemental fiber serving. And if you do get the bloating or the gas, and then kind of try to do it every other day for 2 weeks and then increase. It's something that your body and the bacteria in your gut kind of have to get used to. So I know we all kind of want a quick fix for things, but even if it's uncomfortable at first, it's something that can be useful in the future if you just stick with it. If your stools are too firm, it can also cause constipation. And I know that sounds counterintuitive, but really what happens is that essentially liquids, your body's trying to get rid of the stool. And so liquid stool will kind of come around constipation. It's your body's natural way to try to get things through. And so what happens is that you're constipated, you have liquid running around it. And because there's already what we call a bolus of stool in the gut, it's hard for your gut to respond normally to liquid stool. And so initially trying to get past the constipation, get to regular formed bowel movements, regular formed soft bowel movements over the course of a couple weeks can help in the long term. So something that is mild, not super effective, it's called Colace. You can get it over the counter, called Docusate, and that's in pill form. My favorite thing in the world is something called Miralax or polyethylene glycol. You get it right next to the Metamucil in any grocery store, Walmart, pharmacy, and this is going to draw water into the gut and into your stool without your gut forming dependence on it. So it's not going to be something that impacts the movement of your gut. It shouldn't make you cramp. It just is going to help with those Bristol type 1 pebble stools and constipation to get you kind of in a good place. Milk-O-Mag also does work in a similar way. The stimulant laxatives like the Dulcolax and the Senna, I don't really love them. Your gut will form a dependency on them. And so it's not something that you'd want to be taking every day, but more of like a really only as needed. And if you really just feel like you have something there that's stuck right at the, in the rectum or in the opening, you can use a glycerin suppository. And that's kind of, that would be that impact. Is like, oh, it's stuck and I just can't get it out. You'd have to be pretty impacted to move on to the enemas, but these are things that people can use for sure. There are many people who have problems where their stool is too loose, kind of in that like IBS-D category of things. And so there are constipating medicines like Imodium that you can take. For instance, it's like if you have runnier stools, you leak when you have runnier stools, you need to go to Kennywood, you need to go to the amusement park, or just you need to get through a day. Taking Imodium, there's no shame in that game, and you can do that more of what we call PRN or as needed to help to slow things down a little bit. So this is for diarrhea associated fecal incontinence. And you want to avoid this if you're having the constipation liquid stool type scenario. So there is a little bit of knowing your body involved here. So you'd start with 1 tab or 2 milligrams or a half tab, and then you can kind of take it up as far as you need to. Like you can take up to a couple at a time. But recommend just starting with the one. And before you start taking a few at a time, you may want to talk to your doctor first. Our allies and an excellent tool in treating fecal incontinence are our pelvic floor physical therapists. What they're going to do is help to care for those pelvic floor muscles, care for the sphincter tone and function, and help you to re-coordinate your bowel movements. They're also really great in talking through diet and lifestyle, and they just have a lot more time to sit and individualize your care. They can use biofeedback, which is essentially like neuromuscular training, and often will have inserts like vaginal inserts to where you get real-time feedback on whether you're engaging and strengthening those muscles. And so that's really what biofeedback is it's non-invasive, but it's a series of pressure sensors essentially where they can assess tone and squeeze. It helps you to know that you're working in the right place. There are some devices that are uncommon. One of them is an anal plug. I have never really seen one or prescribed one, but in theory, they do exist. There is an Eclipse system that is really promising. It's almost like a pessary that can go on the vagina with a balloon that inflates and pushes back on the rectum. And then when it's time for you to have a bowel movement, you deflate it and have a bowel movement. I will say, unfortunately, this is newer. I know on this side of things with AHN, we don't have them here. We're hopeful to in the future. It's just been troubling to get the kit in the office, but would be something to look out for. An excellent form of therapy for fecal incontinence, and the number one most effective treatment is something called sacral neuromodulation. So essentially, if you've spoken with your provider, you've tried the fiber, you've worked on your diet, you tried a little pelvic floor physical therapy, and you're just not at goal, we can talk to you about a minimally invasive treatment, really targeting the nerves that go to the bowel and the bladder and can help to regulate the emptying mechanism. And so this can be used in people with or without sphincter defects. And so the age-old dogma was that basically it's like, well, if you had a big tear when you had a baby and there was a defect in your sphincter, then you had to have a sphincteroplasty. That's actually not the case anymore. And sphincteroplasties are very rarely performed because they're not that efficacious. I believe I do have a slide on it in the future. But sacral neuromodulation, what it's working to do is with a little stimulator, think of it almost like a bowel pacemaker. It's talking to the S3 nerve root or the nerves that are going to the bowel and mediating sensation and function. It's FDA approved for urinary urgency and frequency, urinary incontinence, urinary retention, also fecal incontinence. Put a little lightning bolt to remember this. It works extremely well for people who have urgency incontinence. 80% of people will have improvement, 40% with resolution. But for fecal incontinence is where it really shines. And 80 to 90% of people will have significant improvement. And about half of people can have complete resolution in their leakage of stool. Like I said, this can be used for people with or without an anatomic defect, like a sphincter defect. And there are studies that show sustained improvement up to 5 years. But I'll talk a little bit more about kind of what it is and how long it can last. It has very low rates of complication and need to explant, really meaning for like infection or something like that. It's 3% or less, 3% chance or less that you'd ever have a problem after getting this placed. The way we do it is that we would do an exam in the office, start our conservative things, and then if you decide you want to do sacral neuromodulation, we can actually do an office-based trial. The wire that serves as the electrode is so thin that we can actually place it through a needle. And so what we do is we come and we numb up the area on the top of your butt cheek where we place these, and then you wear it for a couple days up to a couple weeks, and then just see if it works for you. If it works for you, then we would do the full implant under light sedation, basically like colonoscopy type sedation. That can be done in surgery centers or in the regular OR, but you don't even need to be fully asleep. If working well, the battery can last for up to 12 years. And so even at that 12-year mark, when the battery has died, we actually just don't even need to replace the lead if it has been working well. We can just replace the little battery, which is about the size of a quarter, and sits underneath a natural fat pad at the top of the butt cheek. So if you really went feeling back there, you would and feel a firmness and know that you had it. But no one else would be able to. And it's not something that really is sticking out or hanging out. It's very small and it gets placed a few centimeters underneath the skin. These are imaging compatible. The old devices, maybe 15 years ago, 10 years ago or so, you were not able to get an MRI. They are now MRI. I did mention a little bit about sphincteroplasty, and really what that means is reconstructing the anal sphincter muscle. We do those pretty uncommonly. It's really about patient selection, thinking about like a young patient who has recently had an obstetrical tear or injury going through the sphincter. However, they don't tend to hold up. There's a high rate of complications, up to 25% of them dehisce. That means that they can break down or break apart, you can get infection there, you can get a fistula in that space. And really, we've only shown that about half of people find this to be effective out, 5 to 10 years. So it's not often our first go-to anymore, just because the sacral neuromodulation tends to work so well, even in people with sphincter defects. Other treatments that are kind of either up and coming or not available in the United States, there is anal canal bulking. That I do believe that's FDA approved. I don't actually know of anybody who's doing that yet, but that's something that will probably be on the horizon. And the colorectal surgery may be doing this already. When I was in training, I did a simulator on this when I travel, but we don't actually have that available here. There are other things not available in the United States, like anal slings and sphincter specific stimulators. We don't do those here. And then ultimately in patients who are exceptionally bothered, the colorectal surgeons can offer you colonic diversion, which essentially means detaching the bowel from the rectum and then bring it up to the abdominal wall. And the people that quote have a bag, that's colonic diversion and would really just be a last ditch effort, last step. So in conclusion, accidental bowel leakage or leakage of stool is very common. It's really impactful on quality of life. And these are important things that we should all be talking about with you and that we hope you feel safe enough to talk about with us. Reviewing the medications that you're taking and your food intake is incredibly important. The fried foods, the caffeine, all of that are going to be really impactful on the quality of your stool and on accidental bowel leakage. Many of the treatments are conservative for this problem, starting with the fiber, the lifestyle changes, over-the-counter things, and then physical therapy. And then ultimately, you have allies in your care when it's time to move beyond that or even to talk to you about that. Talking to your primary care gynecologist can also be, they can be a good first start. And then ultimately, your friends in urogynecology like myself or colorectal surgery are here to help you, with the more procedural things. Pelvic floor physical therapists are also happy to talk to you about this. There are some resources that I wanted to mention to you. Voicesforpfd.org. I mean, they have just a wealth of resources for a myriad of pelvic floor disorders, urinary incontinence, bowel incontinence, pelvic organ prolapse. You can find a lot on that website. I have it here. I have another website here. It's called IUGA, IUGA. It's our International Society for Urogynecologists. And they have patient leaflets. So if you type in IUGA patient leaflets, tons of information about pelvic floor disorders in a variety of different languages. So we can provide those to our non-English speaking patients as well, which is really incredible. Right. This is the list of urogynecologists within Allegheny Health Network. We have a wide coverage area across Pittsburgh, north, south, east, west, central. We're here and we can help you with this problem. And I'm happy to take any questions.
Awesome. Thank you so much. Yes, feel free to submit your questions in the chat and we'll start going through them now. Can you reiterate which supplement you said did not create dependence?
Miralax. The fibers in the Miralax will not create dependence. Miralax is called polyethylene glycol. It is a stool softener. You can get it over usually like in the pharmacy section, like where you'd get fiber and some of the enemas and stuff like that of like any grocery store, Walmart. It's in a white bottle with a purple cap. You can get a generic version that's a little less, it's not super expensive, but the generic is even less expensive. And it's something that you can take every day and your gut will not become dependent on it. And this is specifically to help with constipation. I have all of my patients start taking it a week before surgery and through surgeries, and it can be really life-changing for people with constipation in general. And it's something you can take every day. It's safe to take every day for both adults and children.
Thank you. Are there any simple pelvic floor exercises you recommend to ease incontinence?
Ultimately, so we talk about low tone and high tone problems with the pelvic floor. The high tone is like kind of like the urgency, the pain, you know, the problems with having bowel movements. The leakage with stool or leakage of urine, those are low tone problems. So you want to do things that are going to increase the strength of the pelvic floor. Colloquially, we call them Kegel exercises. It can be nice to see a pelvic floor physical therapist at least once to at least have them guide you into doing those Kegel exercises. And then they'll also kind of talk to you about strengthening your core. As you strengthen your core, it will strengthen the pelvic floor. And some of the exercises that can also strengthen the pelvic floor are the ones like squats and lunges. Those will strengthen the pelvic floor as well.
And we actually got a question about additional resources, so I'll have you click to the next slide, please. If you have to drop but want to join us for an upcoming session, we're going to talk about IBS and gynae cancers in the coming months. They're not posted for registration right now, but they should be in a couple weeks. So you can use that QR code if you want to bookmark the page. If you would like to book an appointment with one of our amazing urogynecologists, you can either call that number or visit findcare.ahn.org to look up our physicians. And if you just want to learn more about what we offer, you can scan that QR code. So we'll leave this up just in case anyone wants to drop or take a picture of it. All right, next question. Can gastroparesis cause ABL?
Gastroparesis is primarily, we talk about upper GI and lower GI. Gastroparesis is really upper GI, and that's like a slowing kind of like in the stomach and the beginning of the bowel. That does not often cause accidental bowel leakage. It's more like lower GI. That's the problem. So not directly that I could speak to, but maybe a symptom of something else that could cause ABL. Like for instance, like gastroparesis and diabetes come together. And so the diabetes can be leading to accidental bowel leakage by also impacting the lower parts of the GI tract or potentially the medications that you're on for diabetes.
Is there any known correlation to endometriosis and incontinence?
So endometriosis can lead to pelvic floor dysfunction in general. It tends to be higher tone problems. So pain with sex, difficulty emptying the bowels, and like constipation and potentially dysenergic defecation is what we call it when essentially the pelvic floor squeezes instead of relaxes. And then urinary urgency, incontinence, and pain. So endometriosis itself doesn't tend to lead to bowel leakage. Can lead to bladder leakage in the sense where some people have kind of like an irritable and high tone bladder, but not often bowel leakage.
And can childbirth cause fecal incontinence even if it's been a very long time since you've given birth?
Yeah, absolutely. So in childbirth, there is almost always some kind of trauma or insult to the pelvic floor. Even if you don't have a tear down through the sphincter, very often just the muscles at the base of the vagina or those levator muscles that I kind of highlighted in green there, they probably underwent some form of at least a stretch injury during childbirth. And then with age, the natural aging process, menopause, loss of estrogen, that insult kind of compounds over time. So yes, 100%. We often see childbirth injury kind of rearing its ugly head later in life, for sure.
And what is the earliest age that fecal incontinence can occur?
It can occur at all ages, but certainly is more common as we age. Like I said, probably only about 2% of people who are younger than 40 are going to experience fecal incontinence. and up to 15% by the time we're 70. So it's something that can happen in all ages, but certainly is going to increase with age.
And then what are any lifestyle changes you recommend to patients who are dealing with this to try to be more comfortable and confident day to day?
Mhm. Exercise, exercise, exercise. Like I mentioned about the squats and seeing a pelvic floor physical therapist, really just strengthening the legs and strengthening the pelvic floor can be impactful. Um, Weight loss is challenging for all of us, but will have heavy, heavy impact on fecal incontinence. And then ultimately the types of foods that we're eating, increasing um, kind of like the natural foods, just kind of like the meat, veggie type stuff, increasing the fiber and decreasing the refined foods, the processed foods, and the high saturated fat foods will certainly lead to changes in stool consistency and decreased fecal incontinence. So it's kind of like the age-old dogma of diet and exercise. Um, will definitely have an impact. And if not a cure, then we do have the procedures.
And kind of along those lines, does running, Zumba, or other fast moving exercise contribute to an earlier onset of incontinence?
It should not, as long as you are protecting your pelvic floor. But those things specifically are not increased risk for fecal incontinence. Things that we worry about are like heavy lifting and straining. Those are risks for, and something I regret that I didn't mention more of today, um, is that heavy straining, heavy lifting, chronic cough, chronic constipation, anything that's really causing you to bear down over the course of a lifetime can increase your risk of something called pelvic organ prolapse. Childbirth is a number one risk for that as well, for the same reasons why it causes fecal incontinence. But um, anything that can lead to a structural defect, where there's a pocketing of the rectum, like with prolapse, that could increase fecal incontinence for sure.
If you suffer from fecal incontinence, is there a higher chance you'll also suffer from urinary incontinence and vice
Yes,
versa?
yes, for sure. Absolutely. And we treat both in urogyne
Uh,
simultaneously.
can nerve damage from conditions like diabetes contribute to this?
Yes, for sure. And so that's why tight diabetic control over the course of a lifetime will reduce the risk of this happening.
How can you talk to your family or friends or people you're around frequently if you suffer from this without feeling embarrassed or ashamed?
Well, to kind of start with different groups of people, I would say I hope that your providers are creating a space where you're feeling more empowered to talk about this. I think as we as subspecialists talk more about this and enlighten, um, you know, primary care, other type providers, that there are treatments available, it's just becoming a little bit more of a comfortable space for everybody because it's a little more triggering. It's like, oh, I know who to refer you to for this. I know what to do about this. It's not just that, oh, this happens with age anymore. We have good and effective therapies for it. So it's worth talking about. So in that space, I do hope you feel empowered. And there are people like us who certainly do this. It's our bread and butter, every day. It can be challenging, I know, for all of us to talk to family and friends about it, but just I hope that like me going through some of those numbers in the beginning with regards to prevalence, one of the things I hear so commonly in my office is that I had no clue this was so common. People don't really talk about it. And I think that you would be surprised to know who else in your circle is also suffering from this. And so you may have some more companionship than you would anticipate, just because these are such common problems. Up to 80% of women will experience some sort of pelvic floor disorder in their lifetime, including pelvic organ prolapse, bowel leakage, or bladder leakage, just, and skyrockets with age. So you may be surprised to find that someone close to you is also suffering, and you can provide support to each other.
So we'll wait another minute just in case any other questions come in. Go ahead and submit them now. But just wanted to plug really quick. I got a couple questions about recordings of these sessions. So I put in the chat a link to AHN's YouTube page where they actually have a playlist of all group chat talks. So if it's one that we've previously done that you want to see, or if it's one that's upcoming that you might not be able to attend but want to watch it after the fact, will be able to click that link to go and be taken straight to our YouTube. And we didn't have any other questions hit the chat while I was saying that. So we'll probably wrap up for today. So, Dr. Miceli, thank you so much for being here with us and sharing such great information. Thank you, everyone who attended. We hope we'll see you at another group chat, and I hope everyone has a great day. Thank
Yeah,
you.
great. Thanks for having me. Thank you.